Hi everyone, once again Vincenzo Berghella from AJOG MFM. We're going to go through highlights with my dear friend Dr. Mhatre. Mo?
Hi, everyone. Nice to see all of you. I am Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston, and I'm the director of the MFM Fellowship Program at Tufts. For those of you who aren't familiar with our typical format, what we do is we go through all of the incredible work that's been published in the past January issue, and we pick 4 of the articles that we want to highlight today. These are articles that we're selecting because they have clinical implications for anyone who's managing pregnant patients either on the labor floor or in the office, and they are of a robust study design. We have the presentations as a kind of highlight feature, and we're going to do visual abstracts today, but you can feel free to read the articles in completeness in the AJOG MFM website. And we're going to start off today with Dr. Berghella with the first article.
And again, some of you may have noticed I'm wearing a special hat, EGLES Eagles, world champion. I could not resist. I actually lived most of my life in Philadelphia, which has treated me so well. So celebrating big time. So here's the first of the 4 articles, effectiveness of ultrasonic cerclage for reduction of extreme preterm birth in twin pregnancy. So this is a meta-analysis of twin pregnancies with a short cervix. There are 3 randomized studies and 11 cohort studies that this particular meta-analysis from the Dutch group put together. They were looking at early preterm birth in this very, very high-risk population, of twins with a short cervix. And basically, in the randomized studies, not much in terms of difference or benefit, while in the cohort studies, which again, much bigger sample size, but the issue of retrospective cohort studies, a hint of possible help with ultrasound indicated cerclage for twins with a short cervix, with even higher gestational age of delivery and lower rates of neonatal, adverse outcomes. So we're doing actually randomized studies on this at Jefferson and affiliates. I think more to come, but it's really a very hot topic. And we thought with Mo that this was a worthwhile kind of review where we are so far. Certainly SMFM, AJOG, etc. don't endorse this yet, given the lack of level 1 evidence.
Excellent.
No?
All right, the next study is from a group in Israel, and it was evaluating, does combining warm perineal compresses with perineal massage during the second stage of labor reduce perineal trauma? This was a randomized control study. What they did was they evaluated patients who were in the second stage of labor, who had no history of significant perineal laceration or Crohn's disease, had less than 5 births, and do not have a nut allergy. And the nut allergy is because they're using almond oil for their perineal massage. So everyone in the study was receiving perineal massage in the second stage during contractions. And then half of the group, 206 patients, also received warm compresses from anywhere to 10 to 30 minutes that was done in between the massages. And then after delivery, there was a blinded senior midwife who evaluated the perineum and did a rectal exam and determined if there were any perineal lacerations that required suturing. And so their primary outcome found that adding warm compresses to perineal massage did not make any difference in the rate of perineal lacerations requiring suturing. You can see about 43 to 45% in both groups. And they also did a subgroup analysis, and they found there was no difference depending on the degree of the repair or if there were primipara or multiparous. Of note, none of the groups had a 4th degree laceration, and only 1 patient in each group had a 3rd degree laceration, so still on the milder spectrum. But what this found in this study was that the spontaneous perineal laceration rate was unchanged when you added warm compresses to perineal massage in the second stage of labor. So certainly it's a common technique that is used by a number of people with that thought, but the data right now doesn't seem to suggest that it's going to make too much of a difference, though it was underpowered for the more severe lacerations.
Yeah, a quick comment. There are meta-analysis randomized studies saying perineal massage by itself works.
Yeah.
Versus no massage. There are, again, meta-analysis randomized studies saying that warm compresses, no warm compresses also work. I think this was novel, and so what presented by you saying, while they work separately, if you do one, perineal massage, there's more evidence. Maybe warm compresses, do they make a difference or not? And, more research, but interesting data. There's another one putting together level 1 data. This is another hot topic, I think. This is dial-a-PAM versus other methods for cervical ripening in third pregnancies, and individual patient data meta-analysis, which is the best meta-analysis. They got a kind of patient-level data from 4 randomized studies. This is the group led by Dr. Sahad with a lot of other great investigators, as you can see at the bottom of the slides. And basically, they didn't see in their primary comma difference in terms of cesarean rate. They did see decreased rates of tachysystole and non-reassuring fetal heart testing, and better patient satisfaction with improved efficacy with multiparity associated with the dial-a-PAM. So I think, even thinking about, which this didn't look at, but outpatient ripening, which is done more often, balloon, etc., dial-a-PAM, in some places it's not that expensive, but cost effective is an issue. Certainly, this begins to be an alternative to other cervical ripening agents, especially since compared to prostaglandin, may not have much in terms of adverse perinatal outcomes like tachysystole and non-reassuring fetal testing. So more to come, but an interesting review.
Absolutely. And then to round it out, this was a non-inferiority randomized controlled trial from a group in South Carolina evaluating the use of amlodipine versus nifedipine extended release for management of postpartum hypertension. So as we know, we typically have been using labetalol and nifedipine. That's been well studied in pregnancy, and I think the practice has been continuing those in the postpartum period. But other agents are not well studied as much, or the data is not as clear. And amlodipine is used quite often in the non-obstetric population, and has been found to be effective and well tolerated for hypertension control. So this group was trying to evaluate how they could use amlodipine versus nifedipine. And they would randomize patients who had delivered, and before they were discharged, they had a diagnosis of gestational hypertension, preeclampsia, or chronic hypertension without needing antihypertensives earlier in the pregnancy. And they randomized patients to either amlodipine at 2.5 milligrams once a day, or nifedipine extended release 30 milligrams once a day. And then they left it up to the discretion of the clinical team if they were going to increase or decrease their dose, add another medication, discontinue it, et cetera. It was a pragmatic study. And what they found was looking at the time for delivery to discharge, they wanted to tell if amlodipine was non-inferior. So they divided that by, or determined that by 24 hours. So if you needed an extra day in the hospital, it was considered an inferior treatment. What they found was that amlodipine was not inferior. They had about the same time in terms of hours for median time of delivery to discharge. And they found that both groups had similar amount of reported side effects, but that the amlodipine group was discontinued less frequently. So there was still the same number of readmission rates, same kind of blood pressure levels at the time of discharge, but it did seem to be as another option for all of us in terms of other use or other agents to use for postpartum hypertension, especially since it seems to be better tolerated by patients. So another possible agent to consider when you're evaluating patients postpartum for hypertension control.
Great, and that concludes our 10 minutes or less. Again, fly Eagles. Thanks, Mo, for this. Always wonderful to have so many of you on, and we'll see you soon, probably later this month, to look at the next issue of AJOG MFM. Thanks for following us, so many of you. Thanks, Mo.
Thanks, everyone. Take care.